Good afternoon, everyone. Thank you very much for joining us for Advanced Echo Teaching in Critical Care today. What a wonderful pleasure it is to introduce Yang again. Yang is an intensivist working down in Melbourne. She's the current chair of the Ultrasound Special Interest Group for our ICU college. She's the senior lecturer with the University of Melbourne. She's an absolute echo guru, has the FASE qualification. Yang, it's a real privilege to have you coming back talking to us about this. This is the second time you've given this talk. I missed the first one, I can only listen online, so I'm really keen to hear the updated version of this, and thank you very much for joining us. I know you've had an incredibly busy clinical week, so good on you for doing this. Thanks a lot. Over to you.
Thanks, and thanks very much, everyone, to coming to this. And it's my pleasure to share some of our very little experience with you. And I think that this is a great forum. And since that all your guys are going to be potential the lead clinicians in echocardiography in your own hospitals, and going to be the future of our ultrasound special interest group as well. So I wish you all study well and pass the exam, and ongoing enjoy echo. So my talk today will be focused on mechanical circulatory support and ultrasound. This is an update talk from the previous talk. So some of the information are overlapping, but I just think they're very important. So I sort of remain that there, but there are a lot of new cases got added in. So first of all, I just want to decline that this lecture contains a lot of unpublished data and only used under author's permission. And I don't mind to share all of this because in the end of the day, the whole purpose of publishing something is to share the knowledge with others as well. So thank you, Sam, for giving the forum the opportunity, and that's great. I used to be very normal, and until that I've done my fellowship in Alfred as Advanced Cardiology Fellowship in heart failure transplant and general cardiology and intervention and echo. That's how a normal person became a bit abnormal. And then you can start to see the heart in many different locations. So first of all, that this is a picture of an angiogram with the left main here, LAD, and the circumflex. And as you can see here, that clearly that it looks like there is a heart, that's a heart, inside the heart. So we all find that it was a bit romantic during we are doing our angiograms, and just get a special angle, and then you will get a heart inside the heart. And you can also get a heart in the radiography, and then you can also get a heart in the brine. Certainly it's not great for the patients to have a heart inside the brine that is actually gas in the ventricles, and the person doesn't end very well. So what happened is, I just want to say something before we get into the details, that life is not going to be normal again when you suffer from severe heart failure. Yes, as we all know, severe heart failure, and we all know that how serious it can be. Probably that most of the people will be quite familiar about a person had heart failure or cardiogenic shock that lie in the intensive care bed on multiple medications and ventilators and trying to be alive. If they manage to get through this, that they get better. But if not, probably go to a second stage, they're being put on ECMOs and you know, big tubes sticking here and there, and have to be anticoagulated, fighting with all the complications, and manage to survive that. And if young enough, got offered a VAT. A VAT is like a surgical ventricular assisting devices. And in the days when I was starting with doing VAT and transplant, that was at that time, the machine is so big, have to be in the trolley. But nowadays that is actually quite small, and it's just a driving line with a battery, and then you can actually have a backpack. But still that is something that you have to carry all the time. And finally that, you know, some of those people will be able to score the heart. And a heart transplantation has never been a simple operation. It's never been just a scar in front of the chest. It's actually a lot of give and take, and a lot of families and patients, actually they're so committed to their heart, and certainly change their lifestyle. And it is not an easy way to go with a lot of things. So yes, we can do a lot of things on treating heart failure. We can go from ventilators, inotropic support, medical therapies, to ECMOs, to a VAT, to even a heart. But in the end of the day, that it's not going backwards the other way. So it is a serious problem, and we all hope that we can get our patient not to this degree, but actually backwards. So let's have a look at what actually happened in cardiogenic shock. So when someone suffers from cardiogenic shock, their cardiac output drops, their circulation pressure drops, the end organ perfusion drops, And then it's ischemia, not just to the end organs, like the livers and the kidneys and the brain, but also to the heart itself as well, because our heart also requires blood supply. And when the blood pressure is low, and the heart is actually getting progressive dysfunctional, and then the death spiral occurs, and then finally that people die. It's not really matter too much what you do in this sort of phase, because it doesn't really matter. You put a new heart in, you put on ECMO, you put on impeller, you put on all sort of things that you want. You may not be able to actually get this one back to that because the damage is made. However, if you're able to catch them early enough, then potentially some of the patients are actually salvageable, and they may reach myocardial recovery afterwards. And that's what we're aiming for. So just a very quick sort of recap of what are ECMOs or what are impellers. These are ECMO, that's just a configuration of the arterial venous VA ECMO in the femoral approach. You can see a venous line coming here that's sucking blood from the right heart, and then arterial line refeeding back to the system. And as you can see, heart pump this way, flow go this way, there is a problem with it, but most of the time that it is okay. And then also there is an oxygenator here. So therefore that if the lung is diseased as well and not able to oxygenate, that this is actually oxygenated blood back to the bodies. Usually we'll require a backflow cannula because of the large size of the cannulas to the legs. And the backflow cannula can magically reduce the risk of ischemia of the limbs. And this is a percutaneous left-sided ventricular assisting device. It's called the Impeller. It's a LVAD, and this actually goes through a driving line through the femoral arteries, and then it passes through the aortic valves, and then it got the pump sitting actually here and sucking blood from the ventricles. And this is called the Impeller. So device-wise, that the Impeller is slightly newer than the ECMOs, but not as established as the ECMOs. So what are we going to use echocardiography for in the mechanical circulatory support? First of all, we are using that for diagnosis and for decide that whether, let me get back. So decide that whether we should get what sort of devices to put in, for example, like what sort of configuration we need, whether it's an ECMO, whether it's an impeller, whether it's something else, or whether it's a combination of both. We certainly need to assess the function of the LV and the RV and trying to figure out that the function of the valve as well. And then we want to look for potential problems such as, AR for the ECMO circulations or AS for the impeller insertions. And we're certainly looking for other complications such as LV thrombus, shunt anywhere, and pulmonary hypertensions. After the device was put in, that the echo can be used to looking at the function of the devices, the cannula positions, the cardiac volumes, and then can check for potential complications such as hematoma, intracardiac thrombus, or failing of all the conduits in all of the populations. And then you can use that to weaning, adjusting the flow for potential avoid of all the complications such as LV distensions or shutdown. And finally, that it is extremely useful in explantation as well. I'll just share you with a couple of simple cases that we are actually going through. So first of all, that 45 years old gentleman that he suffered from an anterior STEMI. When he arrived in hospital, he was not in shock. Had a primary PCI to his LAD. Immediately after the procedure was done, he had APO, he got intubated. And while the anesthetic drug touched him, he crashed. And then with basically a huge amount of inotropes, with 50 of NORAD and adrenalines, and SATs was sitting in the 70s on 100% of ventilation. And then quickly went into VFVT and PE arrest. So ECPR was started, that was in the cath lab with the ECMO machines. What we're using the ultrasound for is first of all sizing. So how big we can put in the cannulas. Certainly you want a bigger venous multi-phase cannulas, and then you probably want a decent size of arterial cannulas as well. So usually when you start to sizing, it's actually quite simple. You can measure that, like for example, it's 2.5 centimeters, so 25 millimeters. And then times 3, that's the biggest gauge that you can put in. So usually you should be able to, in the adult squeezing of somewhere around the 28 to the 32 French venous cannulas. So the ultrasound is certainly very useful to looking at the sizing and how big you can put it in. also that it can be looking at the guiding the procedure, looking at the needles. So as you can see from here that this is a needle approaching to the femoral vein. You can directly see that where it's going from. And we do like 12 o'clock insertion. So therefore that this one clearly it's a bit on the side. It's probably not ideal. And you can see the artery is just
sorry, Sam, sorry, really stupid question. That last picture that you sent, that was the femoral vein in long axis there as well? Or is it you looking at the IVC? You're looking more further up?
That one is the IVC, yeah.
You care about the whole, the size of the vessel all the way up, is that right?
Yeah, you do care about the whole size. So when you measure, you do need to measure the femoral vein, but not just IVC. But yeah, the one that I sent is looking at the IVC sizing, yes, but that's usually quite big. So the limiting step will be the femoral vein, and the femoral vein is usually about 1.5, somewhere around there. So it's unless there are some sort of venous problems in the past. Yeah, but we do use sizing with the femoral vein, which is in the last picture on the other side, which is the femoral vein, but also the IVC.
Thanks. Sorry to interrupt. Thank you.
No, good. Yeah, so this one is just needle approaching to as many procedures that I think that you're very familiar with needle, selling the techniques, and that's what you're looking at. And then the next one, oh, what's happening? Sorry, I think my PowerPoint just decided to go. Sorry about that. One second. Can you still see the screen?
Yeah, it looks great. We got it now.
Beautiful. So after the sizing, and then now you can actually place the guide wires, and certainly that you want the venous guide wire in the vein and the arterial guide wire in the artery. Therefore, that for checking the venous guide wire, that we use the subcostal view, that looking at the IVCs and confirm that the wire was actually inside the IVCs. And then you can start to dilate and pushing up the venous cannulas. And the ideal position for the venous cannula is actually quite high up at the SVC and IA junction for the best flow. So therefore that sometimes that a tall guy actually do require quite a long cannula to actually go in. Otherwise, even if you're up to hill, you're just below the liver and it's not going to suck in very well. Especially for those multi-phase, they really need to be high up to the SVCs, which is ideal. So therefore that's how you see in the transthoracic, in the subcostal views, that it's sort of past the right heart and then sort of getting into the IVC. And you can certainly see that in the II as well. So this is after successful venous cannulation, you can start to do the arterial cannulation. And this is just a 2D picture showing that there are differences between arteries and veins, and arteries are usually quite thick-walled, less compressible, and veins are usually quite thin-walled, very easy to compress. It is very confusing at times when people start to trying to put colors on. The reason I'm saying that is because, as you see, when the color setting is correct, and then you got arterial, you got venous nerve flow, but when the color setting is incorrect, everything will go very, very colorful. And in the ECPR setting, unfortunately, that because of the backflow from the right heart, and also the decrease of the anterior flow from the left heart, then both of the vein and artery can look very colorful and had a lot of flow inside or have no flow inside at all. So therefore, really do not rely on the colors. That I see so many times that people look at the colors and end up with the cannula in the wrong spot. You really need to have a look at the vein, what it looks like, and the artery, what it looks like on the 2D pictures, and trying to define that from the anatomical point of view instead of from the color point of view, because the flow may not be that reliable when people are in this sort of extreme state, especially during CPR. And then after you successfully put it on, then you can start to put in the backflow cannulas, and the backflow cannulas need to be sitting in the superficial femoral arteries, not the profounder. So that's the first one here, that you can certainly insert that through the ultrasound guidance as well. And then afterwards, then after all the flow had been connected, make sure that the leg actually got checked, because sometimes that, although that people may think that they did put into all the right places, but however, the leg is still not perfused. So we do use the ultrasound to check the legs and make sure that in the popliteal region and in the femoral distal region, that there is actually flow towards to the leg, which, as you can see here, there are flow there, there are flow there, there are clear flow there, and then there are pulsatile flow in the leg. So we'll be quite happy with that. Some of the patient will end up with going for CT scans, and that's what this cannulae will be looked like on the CT scan. So venous cannulae up there, and then the arterial cannulae is here. Afterwards, that maintain the ECMO flow is usually a problem, and some of those may not be able to flow very well. That every time you dial up the flow, either the excess pressure is too high, or the patient's blood pressure is not high enough, or too low, or all those sort of problems. And I think that if you do have a flow problem, usually means that the patient did have a problem. So there are a couple of things that immediately need to be checked for, such as is the vein is actually being compressed, is the line is actually got kinking or any thrombosis inside, that's easily checked. Make sure you check the heart, because in tamponade situations, the right heart got compressed and there may not be too much flow there and end up with shutdowns, and it's not going to be maintainable. Check for the pump failure, check for, LV distension, flooding the lungs. And I remember one case very well that the flow just didn't go very well and the heart looks great. And in the end, it was actually a liver laceration secondary to the prolonged CPR, and the person was actually bleeding inside. And that's why the flow could not be maintained. So immediately after initiation, if you have big troubles with flow, then think about all these potential reasons that they are potentially treatable on the other hand side. So just on this one showing that the heart is very poor, and the other one showing that basically you can't really see the right heart is totally set down. Have a look there. No right heart. And then start to monitor all the complications with peripheral via ECMO. So as you can see here, clinically, you might see some pinky sputum coming out from the trachea tubes, which are APO pictures. And on the echoes that you'll be able to see that the LV is really blown out, that looks very, very big. The LA pressure is so high that everything got pushed towards the right-hand side. And then the RV is sat down and quite small. And then clearly when the RV is not having enough flow, they don't pump very well as well. And there are other things you may be able to look at, which I'm going to go into details. But this is clearly very worrying, because that's the LV distension on the peripheral via ECMO. There are a couple of consequences of that. That first of all, as you can see, the wall tension is very high. That the pressure inside this chamber is extremely high. When the wall tension is so high, the coronary flow to the heart is actually reduced, and it may potentially cause more myocardial infarction, and potentially leading to very, very bad result. So therefore, that this is one thing about the heart. And secondary, when the heart is so distended, the lung will not be able to cope, because all this blood will not be able to flow into the heart and get to the pulmonary, get through the pulmonary circulation. So therefore, the lungs will actually be flooded with a lot of pinky sputums, and you will not be able to oxygen the patient very well, which is another main problems that when this scenario happened, is a main complication. So that need to be dealt with immediately. And even worse, that if you see this, that the aortic valve is no longer opening, and then there are AR in systolic. I'm not the first person to describe this, but apparently that the systolic AR, I believe it's described by a intensivist with the name of Josh, that in the Alpha Hospital, and first find. And if you actually see systolic AR, that's pretty bad. That means that the pressure inside the aortic root is so high to a degree which the valve is no longer open or keeping sort of fixed position, and even in systolic, that there are aortic regurgitation into this chamber. Even 10 mils each heartbeat. Imagine that after, like 100 heartbeat, there will be like 100 mils there, and then, the LV is very easily to distend out. So that is one of those things that you're looking for when you immediately initiated via ECMO, that is systolic AR. Usually that means pretty bad. Even without systolic AR, things can be bad as well. So I'm just going to show you the next picture. It takes a while to load. This is a mid-esophageal 3-chamber view under the toe. And as you can see that things here, that the LA, the mitral valve, the aortic valve, in this case, it's actually the aortic valve is opening and there is no AR. However, that when you put on some blood speckle trackings with all the newer machines, then you notice that actually there is something that was quite worrying, because there are blood clearly going that way. That's good. That's going through the outflow tract. But when I wait a little bit, I'm just going to pause it at somewhere that you can see a bit better. Here you go. So you can actually see blood's going backwards as well. So apart from going forward, it's blood also going backwards. And this is actually happening in the LVOT level. this is not happening at the valvular level. So you will not be able to see this at the normal echoes, but you will be able to see it in the blood bucket tracking that clearly that there are blood stasis inside the LV, and the LV is not emptying. That in the normal circumstance, all the blood should go through the outflow tract. So therefore, when you are seeing blood actually going backwards, that's not a good thing, that this is a pending LV distension and potential Weaning event as well. So there are some criteria for your consideration for venting, that clinically, that if they're in APO on VA ECMO, they have severe differential hypoxia, they're hypotensive, there is arterial line non-pulsatile, or the pulse difference is less than 10 millimeter mercury, or the end-tidal CO2 is less than 10. That means not much right heart circulation. That you really need to worry about is this left heart is actually dilated out. And cath lab criteria, if you did put in the pit lines and then have a look at the LV EDPs, and if the LV EDPs is very high, for example, like more than 25, then most likely this LV wall tension is going to be too high, and this heart is pending to be blowed out. If you do not have the pigtail catheters to actually look into the LV EDP, then you can also use the PA catheter, the PA wedge pressures as well, or the PA diastolic pressure as well, which is very similar to the LV EDPs. The echo criteria, the LV distension, looking at the LV is actually blowing out, it's a very late sign. A non-pulsatile LV, it's a late sign. A systolic AR, it's a late sign. And I just show you the early sign. It's actually have to use some sort of quite advanced technology to look at, which is the blood speckle checking. The timing of the venting is important, ideally less than 6 hours. However, it is acceptable if it's within the 12 hours. And the venting methods that you can put in an impeller, which is the impeller configuration to vent the LV, surgical put in the drain, or use IABP or pigtail. But these two are unfortunately that the venting is not reliable. So this is the ECMO case, and I'm just going to show you another case with the impeller case. It's a 34-year-old female that presented with inferior STEMI, and this person is known to have spontaneous coronary dissection syndrome, which the syndrome means that the person will just spontaneously dissect of their coronary arteries with no other precipitants. And this lady, unfortunately, that she had coming with an inferior STEMI. So she went to the cath lab to have an urgent cath, and then usually that inferior STEMI will check the left side system first and then do the right side after. But while we're putting the angio catheter into the left main, while engaging the left main, that suddenly the patient became very unstable, peri-arrest, and the team was activated and the impeller was inserted immediately while this happens. And then we've done the intracoronary ultrasound, demonstrate the left main dissection, very unfortunate. And then we use that ultrasound to guide the true lumen to put in the stent for the left main and LAD. And she had a full recovery back home in day 5 with the ejection fraction about 50%. Just going to take you through the case about the insertion of the impeller. As you can see through the groin, big boy, by the way, 14th French, just going like that. And then afterwards that the impeller was inserted into the heart with the gauge here, which is sucking blood from here, and the little pump here, which is pumping blood to the aorta. And there are 2 BMW wires already in here to support. One is in the circ, the other one is in the LAD. So this is the insertion of the impeller. And then afterwards that this is the intravascular ultrasound. If people are not familiar with it, it's a very simple ultrasound that it basically go with the catheters in the heart and actually go into the left main and then go inside to the LAD and then go pull back. So when you look at these pictures, it's actually a pull back picture. Sorry, I can't put a very clear picture in because it's too big for any computer to swallow. But however, you can appreciate here, there is a flap. There is actually a flap. So a true lumen, let me just go back a little bit. See, a true lumen, a flap, clots, and bleeding around. That's in the coronary arteries. And you can at some point even appreciate that flap was actually pulsatile. So we know that we found the true lumen. And the problem is if we stem the false lumen, that will be the end. So therefore, we really need to see the true lumen. Look at that flap there in the coronary arteries. So during the case that swan was already inserted, as you can see here, and the arterial line had been inserted as well. This is interesting that you can see the arterial line go flat, okay? However, there are still a lot of pulse in the pulmonary circulation, and then the arterial returned. So what happened?
It's dissociation between the right and left ventricles.
Yeah, correct. So this is actually during the balloon of the left main because the heart just lost the circulation. Therefore, the left side of the heart no longer pumping and fully dependent on the impeller flows. However, the right heart is still pumping very well. So therefore, it's called decoupling. And you usually don't see that in the native circulation. You only see that in the supported vest circulation. So this is a vest circulation. Clearly, you can see here that every time when it balloon, that they go flatlined. And then once the balloon deflated, and then it's pulsatile again. And the person is actually awake, not intubating and talking. So this is the case that in the end, finally, a stent had been deployed in a very high LAD and left main session, and it looks like a very good result. And the person come to ICU and have been supported there. So in ICU checking, we always look at the patient, we look at the equipment, send off some pathology, do some imagings, and then change the impeller into a standard configuration by adding in some heparin into the circuit. And then if the swan hasn't been inserted in the catheter, then we'll have a swan in as well. So this is what they usually look like. They got the impeller here, that towards the apex, the impeller, and then that's the gauge there. And then you will see the swan gas catheter here and dry lungs. And this person is intubated at that time. This is the console of the impeller CP that basically at the moment is running at P6, which is 2.7 liters of flow. It's actually quite a lot of flow. And you can see positivity in the arterial, and then you can see the motor currents go up and down, adjusting to the heart as well. We also put in swans, and then so we can get all the invasive measurements, that including of the cardiac indices, cardiac outputs, and most importantly, in the left-sided vest system, we are very interested in the right heart function and the misfitness as well. So this is what they look like on the echo. As you can see, that not the great echo ever, but however, showing that the impeller was actually in the right spot, that there is a gauge here that was sucking blood, and the whole thing was actually in the right angle towards to the apex. We certainly check colors, and so inflow color, outflow color. So the outflow color needs to be above the aortic valve, otherwise it became recirculation. And then you do all your initial measurements. As you can see, a very poor heart barely moves with the impeller doing all the jobs. And then the outflow, it's above the valve, the inflow, it's below the valves. And lots and lots of artifact when you're trying to do Dopplers with these devices in. And clearly that at this time point, less than 10 is not winnable. So you just need to have more time and more support. And keep going. If you still got time and then everything's stable, then you can start to do your 4D colors and 4D things and just get some fun. But however, that majority of the pictures is actually getting by the 2Ds, and you should be able to get to your answers. That if you move into those, that it's really not much that, like add on to the information that we already know. And then if you attempt to do 4D or 3Ds on the transthoracic pictures, then unfortunately the whole thing just looks like a blob. It just doesn't look very nice. So, but that's actually inside the heart, as you can see. However, routine ICU management would be the post-infarct care, anticoagulation, inotrops, neurovascular assessment of the brain and the leg, and ventilation, and renal and hepatic support, nutrition, turning and pressure care, pain relief, and just the routine thing that we do in ICU. As you can see from the picture here, actually we used about 4 people to turn them, and 1 person is basically just to keep the joints still. Otherwise they bend and the impeller is out. So, and we do use ACTs at times to monitor them, and sometimes we send off APTTs as well. But however, that sometimes ACT and APT doesn't go together, and then become another layers of complexity. So, however, that there are complications which we do need to watch for. That's not necessarily means that everybody will all have these complications, and most of them are quite serious, such as malposition need to deal with, shutdown need to deal with, non-positive LV is not stable, ventricular decoupling, you may have time, RV failure, you may have a bit of time, clots are usually bad. If they arrest or got severe arrhythmia, it's bad. Significant bleeding is bad, like ischemia is no good as well, have a stroke, hemolysis, sepsis, everything is pretty bad. So because of all this badness, and then you end up with in the hospital most of the time to look after those patients, and this is one of our cardiologists sleeping in the ICU office. So talking about position, we use a lot of echoes to do positioning. So as you can see, this one compared to the first picture, that this is very far in. You can see that it's very far into the ventricles. The elbow is already below the valves. And this is after repositioning by pulling back. Can you tell the difference? So initially it was too far in, and now it's pulling back. There are multiple problems with too far in. So first of all, that you may potentially shut down, you get into pec muscles, and then you got hemolysis and a lot of recirculation in between, and just causing problems. So clearly that need to be repositioned to that everybody will be happy and the patient will be quite happy. The other one is even worse, that as you can see that the whole thing is sort of turning around about 90 degrees, and now it's actually not towards to the apex, but actually towards the free wall. We don't like that position very well at all, because there are many problems associated with that. First of all, the pigtail is at the free wall, and then you can rupture the free wall. Second of all, that you can see the cage that actually sucking blood is very close to the anterior part of the mitral valves. You can potentially damage the mitral valve, or you can potentially have severe hemolysis as a consequence. And also the flow won't be great, because you are literally, the cage is in the LVOT. It's not going to have too much blood to suck. So that is a major problem. So that one have to be repositioned immediately to that. And then everybody was much happier afterwards. And the reposition for those are actually quite complicated, require turning and clockwise, but it can all be done at the bedside in ICU under the echoes. So as you can see, after reposition, now the pigtail is towards the apex, and the cage is now deep into the LVOT, or sorry, into the LV cavities. Any questions on those?
I guess my question is that so the echo is absolutely essential for trying to determine position of these cannulators.
Yes, that's correct.
And so transthoracic is obviously, you've shown mostly transthoracic, and if you can't get that, you've got to do transesophageal, because you've got to figure out where these cannulas are going.
That's correct, but most of our patients are actually not intubated because they got dry lungs, so therefore that we have to rely heavily on transthoracics. And ideally, the parasternal and the apical views are the best, but sometimes if you can't get anything, a subcostal can do as well. However, that doing a TOE on these people means that we have to sedate, have to intubate in a very sort of not that sort of stable situations. That it's doable, but ideally that if we can get information from transthoracic, that will be the best. If we can't, then yes, you have to do a TOE or under IIs. That's another.
And so very briefly, the summary that you've said there for is it's got to be pointing towards the apex. It can't be too far in, because you've got to get the elbow out of the way.
Yes,
so
correct.
Not too far, not too far back.
Yeah, 3.5 centimeters to the aorta, the aortic valve, basically. Yeah, and at the right angle. Okay, so that's for positioning. And then when we keep going and look at shutdown event, so this is a shutdown event. As you can see, this is the whole ventricle is very empty. There is no blood inside. The impeller is totally dives in, and then you got hemolysis and red urine coming out. So shutdown need to be dealt with immediately as well. Usually quite simple, just give a bit of fluid and then reposition the impeller, that would be okay. The problem is not usually patient move. The problem is usually shutdown happen is because of their self-diuresing with, the cardiac output. The impeller give about somewhere about 2.7 to 3.5 liters of flow. And some of those patients that they got heart failure, the kidneys are not used to that much flow. And once they suddenly got that much flow, they start self-diuresing and can put out like liters and liters of urine just within very short time. And once you're that dry to a degree which the impeller pump will start to suck more flow. So even with nothing change at the leg, that like the catheter length, however, that it is just like if you use a vacuum, like with the motor head, that the motor head would tend to go in and dive down to get more blood. And when it doesn't get enough blood, then it just trying to dive in. And therefore that usually in a shutdown event, what you would see is the ventricle is extremely small. Patient will be severely hypotensive, like down to the 50s. And clearly the impeller will try to dive in to some more blood. And that is something that you just need to deal with immediately to give some flow, give some fluid, and like a 250-500 boluses, and then reposition the impeller as well. This guy unfortunately have a bit of hemolysis, and this takes about an hour to clean up, but he actually recovered very well from this event. Sepsis, when things are getting a bit pear-shaped with a bit of pneumonia and things, it may not be always heart failure that causing people still on NORAD. For example, in this case, that scratching our head, that just booming cardiac output, lots of cardiac index, is very good right heart function, but stubborn on 20 of NORAD. And the impeller. So in the end, that we decided that this is actually a sepsis, that later on, yes, this person did grow a bug from his pneumonia. So so you need to think why, not just thinking about it's always heart failure. Sometimes that this patient can be in combination with other failure as well, such as sepsis. Bleeding is a problem. It is a taper cannula, it can bleed, and usually they can be settled with some of the manual compressions, and we use What we use here is quite simple, a cotton ball to make sure the angle is correct, and then make sure the cannula is up to hilt, and also that we put a film stop on, only inflated to about 30 to 40 millimeter mercury instead of the usual, like very high. It's just to keep the skin sort of in contact, keep the cannula in position, and they are fully anticoagulated. But however, that if you do that most of the time, that the bleeding will settle, and it shouldn't make a huge difference that to you. That it's when I never had a case that actually need to go to vascular surgery to have that repaired or bleeding badly. So bleeding is a problem, but however, that if you do some of the simple things, that usually it will settle. Finally, talking about weaning, that there are multiple P levels for the impellers, like PA, P7, P6, P2. We are not allowed to turn off the impeller, because once you turn it off, it becomes a severe AR, that it's a conduit in between just nothing, and just going to have very bad outcomes. So therefore, always keep the impeller at the lowest, about P2 or even P1, but please do not turn it off. At the maximum, it gave you about 3.5 liters of flow. At the minimum, that even if you're at P2, which is very low support, it still give you about a liter of flow. Sometimes if they're quite dilated, give about 2 liters of flow, which can be a problem once you remove them. So this is probably just a rough guide regards of the P levels. However, we have 2 weaning protocols. One is a hair wane, the other one is a tortoise wane. And so far that no one used this tortoise wane yet. Well, most of our patients are actually AMI cardiogenic shock, so they go through the hair waning. They usually stay in support for about 2 to 5 days, and then and once everything is satisfied, then they will be able to be explanted. What we are looking at weaning, it's first of all LVOT-VTI, as you can see there, that this person's heart is recovering, that you look at the 2D pictures, and there are also other forms of echo parameters for weaning as well. But not only about the echo that we need to look at, this just look at the ejection fraction and how their heart is going. Also look at other things as well. So we look at multiple things, as you can see here, apart from all the echo parameters. We also look at the invasive right-sided catheterization Swan-Ganz catheter parameters, and we look at the patient and impeller support, and then we sort of in a collegial way with our heart failure cardiologist and our team, that we decide about the weanings. The explantation criteria, I'm not going to get into the detail of those, but however, that it is quite simple and it's very easy to follow. And then basically, if preconditions met, means the patient is stable, and the right heart test, the hemodynamic criteria is good, and then you do some echoes and the intrinsic heart function is good, then they will be good to wean. So therefore, that this is how we actually take out the impeller. So usually we will have multiple people on site, apart from the person that actually taking out the impeller. They need to be sort of manually compressed for more than about 30 minutes to 40 minutes. So usually there are 2 cardiology people there that to compress that, to make sure that they're not too tired with their hands. Have a nurse holding that just in case they're blood shooting out. Have another person to look after the, like the pumps and the ventilators and the patients. Always have the person look at the consoles, and also a person doing the echo while taking the impeller out. The reason is quite simple, as you can see from the picture here, that there is a pigtail at the end of the devices. And when you take it out, sometimes that the pigtail can hook onto the mitral cords. And if you drag very hard, the mitral cord can be ruptured, and there will be severe MR, then it's going to be very bad. So therefore, you just need to watch that thing when it's coming out. And then if it's not coming out in the right angle, you actually need to immediately reposition, clockwise rotation, and then taking it out in the right angle. So therefore, the pigtail does not hook onto anything. It is actually quite important, because in that case, the pigtail did hook onto the cords, and the person had a QMR, and the person had APO straight away. It's extremely quick. So therefore, that after learning that lesson, that everyone that we actually do that, we always on the echo guidance, we definitely look at the hook of the pigtail, not just the impeller itself. So that's that. And finally, that after 3 months, they go home, and then they will come back for an MRI follow-up, just to reassess how their heart's going and the emphasize. For people who are not familiar with cardiac MRIs, this is basically just a reconstruction picture to looking at things very similar to our apical 4 chambers view. So as you can see, pericardial fat here, the LV here, mitral valve here, LA here, RV here, and the IA here. And you can actually see the myocardial flow, the blood inside. This is a leg-linear study, so you can actually see that this is well perfused, and this bit here after the infarct is less well perfused. But more and more we start to find that, especially with the impeller patients, that because of the active unloading and also the improve of the coronary perfusions during the post-infarct period, we noticed that all of these infarct became very patchy. We used to see whole big anterior wall all wide out, couldn't move at all. But now we have patients actually have sort of patchy infarct instead of full mirror infarct. And clearly their functions are quite good and they do not require heart failure services follow-up. So as you can see here, there's a patchy things, they're patchy infarcts, but they're not full mirror infarcts. So that's cardiac MRI assessments post-op. Some people may not be able to wean off and they require escalation of support. Then usually they will be neither escalate to ECMO or escalate to a surgical vet. So therefore that they will require transfer, because our center don't do surgical vet and our center do not do heart transplantations. So therefore that you need to be transferred to a vet center and transplant center. So this is one of the cases that we did a while ago. As you can see that this person is very, very sick. This is the right heart cath. As you can see, the cardiac output is 3.4. Impeller flow 3.6, so the person is entirely relying on the impeller flow. The RV is not working at all. Well, Sam is the RV specialist. Is that RV very bad, 8?
I don't think the heart's doing anything, is it? That's just entirely the impeller doing its thing.
Yeah, that's right. And
God.
we're a bit worried this one, especially when the RV start to fall, because when the LV is not working, that's okay. As you can see, this straight line here, there is no positivity, just the impeller flow, that's still okay. But however, that when the RV is not able to pump, then it became a very unstable system, because blood can easily just build up in the RV, not going anywhere, and then the LV will shut down and then the person will die. So therefore that we really worry about this patient. We gave a lot of RV support, you know, like mirrors and other things, and trying to get the RV up a little bit. The RV just didn't want to move. In the end, that we decided, yes, we are going to do the transport. This is the country's first transport of impellers. As you can see, patient's not intubated. As you can see, it's in the pandemic period. Everything is pretty difficult. It is in winter, it's very cold. We load the patient up to the ambulance, and then I literally need to carry a Vino Go with me. So a Vino Go is, you know, those sort of portable ultrasound devices. This time I carry the Vino Go with me, just in case that during the trip, the impeller got malposition or whatever, that I can reposition immediately. So the patient landed the referral hospital, the vet center safely. And this is one of those ones that you probably don't wish to do it again, but I can see that there is a need for that, especially that not all the hospitals are vet centers or transplant centers. I believe that there will be a lot of, in the future, that more and more of this kind of transfer will happening. The pandemic definitely give us a lot of stress, that apart from looking after our usual heart attacks, heart failures, and all the other, you know, endocarditis plus, and the COVID hits, and then we all sort of stressed, but we still managed to get some patients through. And as you can see, we all dress up, and this is an incredible thing that our team had managed to achieve, and I'm very proud of everyone. Then many lives have been saved despite of the great difficulties. I think that is probably the end of my talk, and save some time for questions, especially around you know, like managing of mechanical devices and severe cardiogenic shock. I think that it's a growing area and certainly very interesting.
Oh yeah, thank you so much. What an incredible place you work in. What incredible machinery you get to use. And it's fascinating to see how much echo is absolutely integral to your care of these patients. And that's absolutely wonderful. I guess I got a bit of a question, please, around, you know, the causes of the heart failure that you're seeing. So clearly you've got to have a multidisciplinary team involvement. So I guess all of these patients with severe heart failure, you've got to be worried about the coronary arteries. You know, how do you find sort of transporting these patients with this machinery that's being used? I mean, surely it must be incredibly tricky to try and care for these patients and move them around. So I guess angiograms are so important for their care. You know, can you talk to me about how you're finding the transport of these patients?
Well, so far we only done one impeller transport. Most of the ECMO transport are done by the Alfred hospitals, and they have already developed a very good transport, you know, team with the ARVs in Victoria, and the ECMO consoles are slightly easier in the way that the console is small, and also that the cannulas are big, and the cannulas are not that, you know, like positioned sensitive, so certainly that it's like 1 or 2 centimeters, it's acceptable. But however, that my own experience with that only one impeller transport, I find that it will be a bit tricky because of first of the road is bumpy and the signals may not be that clear. And secondary, that impeller, it's a temporary devices, as you know, and it need to be positioned correctly. And if it's not positioned correctly, then it can run into trouble. And these are the things that we need to look at during the transport, that just make sure that you have enough equipments that on the road, and also that the correct personnel that actually be able to do so. So we haven't done too many. That so far with all our cases, we only done one transfer, and I think that's the only transfer done in the entire country. But the United States had a lot of experience in transferring those patients. They've done a lot of impellers and a lot of transports. So therefore, that I believe it's just safe to do so. But however, that the Australian experience is just on the way to build up.
Oh, Yang, thank you very much indeed. Are there any other questions for Yang? And thanks again, Yang. It was just a great talk. Any other questions for Yang?
Hi, Yang. It's Emma. I'm the Echo Fellow at Nepean. I just had a practical question, just surrounding how long you guys have had impellers, and how long it took to train like nursing staff, and what were some of the practices that you put into place to establish that program. And how did you establish the sort of collegiality and the sort of multidisciplinary sort of teamwork with the cardiologists and things like that? Just a little bit about the process of that, if that's all right.
Yeah, thanks, Emma, for the question. We are unlucky and lucky in a way. We are very unlucky. We're actually sitting in the western suburb of Melbourne, and as you work in the Nepean Hospital as well, which is sitting in the western suburb of Sydney, then the western suburb people tend to have a lot of heart attacks. So we are one of the biggest PCI centers and STEMI centers in the entire Victoria. We had a very, very good dedicated cardiology team that not only in interventional cardiology, but also in imaging, MRIs, and heart failure services and all of that. When we come to our agreements about 2 years ago, that we definitely look into all different kind of modalities that what we can help our patients most, because resources are limited, that we can't doing everything. So we sort of go with the impeller because we think that most of our patients are acute AMIs, and most of our patients will be able to be PCI-able, and most of them should be able to recover. So therefore that we go down that route. I have to say that we are extremely lucky that the collegiality with both of the teams, that it's such a journey that I can't imagine that anyone have to do it by themselves. I don't think that would be possible. I think that in the end of the day, that when it's sort of a team sort of approach with what we call the cardiogenic shock team or the shock team, that then it became less painful. So therefore that, like we have all our cardiologists and our cath lab cardiology medicals and nursing all trained for the devices. Most of the ICU nursing are trained for devices to ensure that there are ICU nurses, at least to be able to look after such patients each shift. So we don't need extra rosters or anything like that for looking after those patients. And yes, the training, it is quite a lot, but by saying that, once you actually get patients through, and then every person got about a day or 2 or 5 on the devices, and then the person actually rotated through, and it's something that we all enjoyed, and especially seeing that patient working out of ICU or walking out of hospital in their normal day, like day 5, day 7, and then see them actually living in the community with their own heart. That is probably the most rewardable thing. So yes, there are difficulties, and clearly that's not going to be an easy take. It requires a very high level of collegial abilities between a lot of units, probably not just ICU and cardiology, also anesthesia and vascular as well. But however, the result is it's encouraging, and it sort of encourages us to keep going. Yeah.
Thank you. Thank you. Yeah, that was awesome. Thank you so much for the talk. It was really excellent.
Yeah, thank you.
Thank you.
Well, yeah, unless there are any other questions from anyone, I think that probably wraps it up. Are there any final comments from anyone? Yang, thank you very, very much indeed. Well, wonderful talk. I hope you can get some sleep now and step away from the clinical stuff. But I'll talk to you soon. Thank you very much.
Thank you very much. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.
Links in the channel banner.
And thanks for watching.